Hi, this is Pat Iyer with Legal Nurse Podcast, and we're going to be talking about something today that's in the headlines, in the newspapers, as people are grappling with the implications of the opioid crisis. When I have been going through my sources, thinking about who would be a great guest to have on Legal Nurse Podcast, I wanted to bring in somebody who, as a nurse and a legal nurse consultant, could comment on the opioid crisis and some of the factors associated with it. I have with me Kristina Mitchell. She has close to 15 years of hospice experience, managing pain at the end of life, using opioid therapy. She also has a background in case management and in home care, and she's a certified legal nurse consultant. Kristina, welcome to the show.
Hi, Pat. Thank you so much for having me.
Let's start right in with, why do we have an opioid crisis?
Yes, so given my hospice experience, and I believe that there's a lot of reasons why we have the opioid crisis. And first off, I think that the biggest reason why we have the crisis is because physicians and prescribers just do not have long enough to spend with the patients to do the thorough assessment, to gather the information that is needed. And oftentimes the opioid can seem like the simple fix and the maybe band-aid to cover up the issue. When a thorough assessment is completed, that really can resolve the issue and the high amount of opioids that can be given. For example, checking with the patient, sitting down with them, counseling them, checking to see, is there a legit reason for their pain? Do they have a diagnosis that would cause this pain, an injury, and assessing the pain and checking to see, how does that patient rate the pain, and where is the pain? What makes the pain worse? What makes the pain better? Just, using the basics of nursing to assess that, like we've all learned the fifth vital sign. So
Mm-hmm.
I feel that that's a big reason why we've really ran into the crisis. We've just lost time with the patients, and of course there's some other reasons too.
It sounds like you're saying, if I could condense what the information is that you just gave us, is that perhaps it's easier, or it was easier, to put a Band-Aid on the problem without really investigating why the problem existed. Tell us what your opinion is regarding the way that physicians, and I'm sure nurse practitioners as well, were educated by the drug companies in terms of using opioids.
Sure. So, of course, I believe that, they're impacted when drug companies come in, reps come in and provide their pieces of material, and definitely impacts what they're going to prescribe with the last piece of education, the last person who came in and educated them on. For example, with what I see a lot of in hospice is the oncology patients, of course, and really OxyContin and oxycodone. OxyContin is such an expensive medication, and um, a large population of the patients coming from oncology to hospice are on OxyContin, and that is just not in the hospice formulary. So they're switching over to long-acting morphine because they're equivalent and really they have the same effect. And so, yes, I definitely see a lot of that, and definitely believe that the drug companies impact what the physicians and prescribers are prescribing.
And I think you would agree that it goes deeper than that, that there are a number of drug companies who are in the line of fire because of lawsuits, because the allegations are that they minimized the addictive potential of the drugs and marketed them as safe and effective. When we think about the number of people who are dying from opioid overdoses, it's probably not the hospice patient, but it's the young, 18 to 30-year-old. I just saw a notice on Facebook about the death of a boy who I knew growing up who died at the age of 21 from an opioid overdose. He was
Wow.
a sweet little boy when I knew him. His brother was a very good friend of my son's, and I was distraught when I saw the notice about this because he had so much potential and so much life and was a loving little boy. I didn't know him as an adult, but he put the face of the opioid crisis together for me because up until I saw that notice, they were just, statistics to me. But this was a kid who I knew who was funny and ran around and emulated his brothers and was just a great kid.
Right, right. Yeah, definitely. You have to wonder with the younger, a child like that, a younger gentleman, why was he placed on that medication? If it was illegal, legal, what was the situation? And it also makes me think of, I see end of life, of course, but oftentimes adjuvant therapy is underutilized. I see that a lot where when someone really does benefit from opioids, they don't need to be at that high of a dose necessarily if you add in an NSAID. You can really minimize the amount of opioid with adding in an NSAID. And a lot of times, even an opioid may not be effective and they're still on the opioid. The dosage is increasing because they're reporting to the physician that drug is not effective. The doctor increases the frequency and or the dose when the drug will never help, say, the neuropathic pain. We know that it's probably not going to be very beneficial in that kind of pain. And it's the wrong drug, which I see often.
And making sure that physicians and nurse practitioners are prescribing the correct drug is certainly a big part of this. What has the federal government of the United States done to try to step in to deal with the opioid crisis and the prescriptive patterns of healthcare providers?
Yeah, so the OIG, which is the Office of Inspector General, they really monitor and set guidelines, and they have since determining that there is this epidemic, there is this crisis, they have designed what's called the toolkit. And so in this toolkit, it really has this federal government has determined who is at highest risk. So it's a set of guidelines. Who is at highest risk for misusing, abusing, and possibly overdosing on the drugs, and how because there are various opioids. So how can you combine each drug into one category? And so they have what they've done is they have morphine. It's called an MME, which is a morphine milligram equivalent. And so each drug is appointed a number, each opioid drug. So for example, uh, uh, codeine is lowest, it is 0.15, and highest is dilaudid, which is 4. So that just gives you an idea.
Mhm.
Uh, Norco or hydrocodone is 1, which is equal to morphine, and then there's fentanyl, which is 2.4. So that kind of gives you an idea. And then there's a whole calculation. It's called a MED calculation. So that's how you calculate the drug. Once you calculate that drug, then you determine there's three different classes, and there's the they've coined different terms, and there is a high med, that's one of the terms, and that person has an MED, the calculation I just gave you, of 120 milligrams of the average daily medication over 90 days. So 90 days the patient has to be on that opioid, and they're considered high meds if the patient is on 120 milligrams or higher of that opioid. And then there is an extreme med, so that's the second class of who's at highest risk. And that patient classification, the patient is on greater than 240 milligrams for the entire year. So that would be a higher dose. And then there is the patient who's considered a doctor shopper, which we've heard that, I'm sure, if you're a nurse. And that's similar to the high med, where it's greater than 120 milligrams over the 90-day period. But in addition to that, person or patient has been seen by more than or four or more than uh, different clinicians, and prescribed drugs by four or more, and also pharmacies received opioids from four or more pharmacies. So that's who's at risk. And yeah, so the OIG has just set different rules and determined, who's at risk, and identified and set the different calculation, and yeah, so it's different guidelines.
What you just shared makes me think of the times that I did medical chronologies, and I would ask the attorney for those prescription records and find out exactly those patterns that you were describing of a patient who was going from doctor to doctor and getting refills of prescriptions from more than one person who clearly did not know another person was prescribing. And then the medical records might contain a note down the road that would say, you need to sign a contract with me, a pain management contract, that I'm the only one who is allowed to prescribe medications and you won't go elsewhere. I don't know if the pharmacies now communicate with each other, but at a point in the past, you could have, for example, CVS pharmacy branches would all have one central record, but a patient may have a prescription filled by Rite Aid or another drugstore and not know that there were prescriptions being filled at the rival down the street. Do you know if there's now any way that they're talking to each other to share that information?
Yeah, I think that I believe each state has adopted their own system. I know that here in Michigan we have a MAPS system, and it just stands for Michigan Automated Prescription System. And each time a drug or an opioid drug is prescribed for greater than 3 days, a physician or someone who is appointed by the physician or prescriber has to pull a MAPS report, which will ensure that the patient is not an abusing or a doctor shopper, basically, and even the pharmacist can do that as well, as long as they have this what's determined a bona fide relationship. But of course, if a clinician suspects abuse like behavior, they can't just pull it just to check on a patient. So there's that sort of protection as well.
Can you tell us about the categories of people who are excluded from regulations that might be addressed to controlling opioid use?
Yes, so the hospice patients are are supposed to be, according to the OIG toolkit, they are supposed to be excluded. And also any patients with a cancer diagnosis. So that would be, brain, bone, breast cancer, lung cancer, etc. And
Mhm.
also neurofibromatosis, which is the non-malignant. So all of those are included. However, I have seen, working firsthand and in the state of Michigan, we still include our patients. We still require them to fill out this opioid start talking form, which is something the state of Michigan has adopted, and that's since June of 18, where the physician will have to, or the prescriber will have to sit down with the patient and discuss with them the concerns with opioids, risk for abuse, the adverse effects, and make sure that there's no risk for abuse, there's no past history of abuse, have the patient or the guardian sign it, and then that has to be done on even infants and toddlers. No age is excluded. So really, in a pinch and in hospice and terminal patients and in pain crises, it really can slow the process of getting opioid medications.
It just made me think about a next door neighbor who I have in Florida whose husband required morphine on an ongoing basis as he was dying, and his son, who had a substance abuse problem, was trying to break into the storeroom where the morphine was being kept so that he could steal it and use it himself. I have heard of other stories of family members who have diverted drugs. Is that something that you have ever encountered in the hospice setting?
We do encounter that. It's very unfortunate, but addiction is addiction, and yes, we do encounter that. We see drug diversion, and in order to prevent issues with that, when we do see that, we have to do regular pill counts. If we have Roxanol, the sublingual morphine in the home, we have to monitor that closely. Oftentimes I've seen, and I've had to do this myself with my own patients I have case managed, is sending the drugs elsewhere, maybe to a family's home, and having the family disperse X amount to get the patient through, having to pre-draw syringes, having to use a lockbox and supply a lockbox, definitely filling pill boxes, and definitely it's very unfortunate.
Could you share with us any additional insights about how patients are being affected by the opioid crisis?
Yes, like I mentioned before, I feel that it can be a barrier to the patients who really need the medication. That can delay the time that they get the medication, especially in these terminal patients. They can also, since there's such news, you hear this on Facebook, you see it on the TV, you hear people talking about it, you hear it on the radio, this opioid crisis, epidemic, etc. um, if there's a chronic pain patient who's taking drugs, these opioids, and they're at this therapeutic level, there may be some sort of heat that the prescriber is getting to minimize the dose. And then the patient could end up, there could be some sort of disconnect, some animosity between the patient and the prescriber. The patient, then the pain may not be therapeutic. The pain management may not be effective. It can heighten anxiety and end up, anxiety is never good when you have chronic pain. and then also feeling like a criminal when you're taking opioids when it's taboo, can be taboo in this day and age right now. Um, yeah,
Hmm.
I'm seeing some patients really struggling with this.
I remember oncology patients telling me that they didn't want to take pain medication because they were afraid they would get addicted to it.
Yes, I am seeing that. And it with this opioid start talking form that the state of Michigan has adopted, it's very difficult because there is this stigma with morphine. Many people think morphine kills people, especially at end of life, because it is the last drug that patients take prior to taking their last breath. And so hospice nurses are working very hard to eliminate these myths of morphine, and trying to explain how beneficial morphine can be for dyspnea, for the breathing issues, for the pain management. And then at the very start of hospice services, we're handing over this form and we're talking all about the bad things about opioids. But then a day later, we're coming back and we're saying, but here's your morphine, and we really need you to take it. So there's some issues there, but
Mm-hmm. Mm-hmm. I know as legal nurse consultants, we can be asked by attorneys to look at a case in which there was an overdose from opioids. There's so many nuances of that. I've seen a number of cases of people in the hospital who got IV pumps that resulted in overdoses because of either misprogramming by the provider or the patient or their family pressing that pump button too frequently.
mhm.
I know there are allegations involving providers who turn their practices into what's called a pill mill and end up being legalized pushers. Could you comment on some of the things that we might expect to be involved in as legal nurse consultants when there is an overdose, or perhaps maybe not a fatal overdose, but enough of an overdose to cause some anoxic brain damage if the person is revived in time?
Right. So depending on what kind of setting we're discussing, but really just looking at the patient and the protocol that was followed. Um, was the proper protocol followed? Was if it was an in-home patient, was the was the patient um, the first responder? Did they reach the patient in time? Did they evaluate for the overdose? Was it the medication really that caused the issue? Was 911 called in time? Was the Narcan administered? One big issue right now is the Narcan. Right now, a lot of the overdoses are related to fentanyl, whether it be from the street drug or prescription, or something that is fentanyl that was bought off the street. Um, and so with fentanyl, because that MME factor that I explained earlier is higher, and it's such a potent opioid, you really need to administer Narcan at least twice, and it's usually about 2 minutes apart. So you have to keep administering it because it is such a potent drug. So was that followed? That's one thing to really look into. And then was the airway supported? Making sure the airway is open, making sure were rescue breaths given if needed, chest compressions, and if the drug was prescribed, was the proper protocol followed? Were the risk outweighing were the benefits outweighing the risk? Um, and just making sure that oftentimes I'm seeing even patients just coming over to hospice that benzodiazepines are ordered with opioids, which are, that's really probably not best practice.
Mm-hmm.
That can increase the risk for overdose and fatal episodes.
Mm-hmm. I'm also thinking as we're talking and wrapping up this show about the time that I had shingles and which ran down my leg. And for if you've never had shingles, it's one of the most painful conditions. And I was prescribed hydrocodone. And what I described to my husband was I felt like my brain was taken out of my skull and put in a box across the room. I could function, but I found my brain, my thinking was foggy. I was watching shadows moving on the wall instead of doing the computer work that I wanted to do. And as
Mm.
soon as my pain levels subside, I switched over to Tylenol. And when I went back to my family practice doctor, I said, I don't understand how people can get hooked on this stuff. It just made me think, my thinking was so like clouds were surrounding my brain. I know you deal with a
Yes.
different population with hospice, but I think it applies to the curiosity that I have after having experienced hydrocodone. And now I understand from what you just said, it's got the equivalency of morphine.
Yes.
What does it, how does it appeal to somebody who gets hooked on it? That's what I don't understand.
Yeah, I yeah, I don't know. I really don't, I can't really give much input on that at all.
Hmm.
Um,
I didn't expect you would
yeah,
be presenting yourself as an
I
opioid
don't
addict.
know.
But,
Yeah.
my conclusion was that there's got to be there's something that's appealing. And
Mm,
I don't personally understand it from a cellular
no.
level because of my experience with it, but it seems to fulfill a need in the people who are taking it. Maybe they started on it because of neck injuries or back injuries and then
Yeah.
they continued, but it satisfies some part of them that makes it so appealing to them.
It's an escape, definitely, just like alcohol, and it's an escape, and definitely that is why uh, they should be counseled prior to making sure that the pain is legit, that the source is legit, that there's really an injury. There should be some sort of radiology study, there should be some sort of diagnosis. There has to be a diagnosis. I have seen many people who start on these medications, these opioids, and they really do not have a real source of pain and they become addicted.
Hmm. It's satisfying some portion of their biochemistry or their needs. I think of it as like two magnets. If you try to pull apart magnets, they resist to each. They resist being separated. Is what I'm trying to say. And if you switch over the positive and the negative, and you try to put those two magnets together, they'll repulse each other.
Hmm.
I think there's so much more that we need to understand in terms of why people become hooked on opioids, what can replace that need, what are the therapies or the treatment programs, which is beyond what we're going to talk about today,
Yes, yes,
but raises questions, at least in my mind, and presumably in someone who's listening as well.
yes, I agree.
Tell us about the expert witness services that you offer, Kristina.
Yes, I would be, interested in any expert witness services in regards to opioid overdoses or misuse cases, any hospice, home care. I also have a lot of experience in fall prevention, wound care, and any end of life issues. And I have a LinkedIn, and you can find me under Kristina and Kristina Mitchell, and Kristina is with a K, and Mitchell is 2 L's at the end.
All right, so we have Kristina, Kristina, Mitchell, Mitchell.
Yes.
Well, thank you, Kristina Mitchell, for providing us with your insight and your experience today. And for the legal nurse consultants listening, if you've got a case in which you've got questions or need an expert to address the areas that Kristina has shared as her expert witness services, please feel free to connect with her on LinkedIn.
Thank you, Pat.
And to you who's listening, thank you for being part of the show. Be sure to tell other legal nurse consultants about Legal Nurse Podcast, and we welcome your questions and comments. You can reach me by email at patiyer@legalnursebusiness.com. My name is spelled Patiyyer, just like the sign over my head. And I look forward to having you listen to our next show. Thanks so much.